Yes, welcome again to our YouTube channel. Today we want to go through an interesting topic on osteomyelitis. Osteomyelitis is a form of bone inflammation due to the infective process that occurs, maybe an infecting organism. So the bone gets swollen because of the presence of an organism. Now, osteomyelitis can be classified into one, based on duration, as in you can have acute, which is an infection of the bone occurring less than 2 weeks. You can have subacute osteomyelitis, which occurs between 2 weeks to around 6 weeks. And then chronic osteomyelitis, which occurs beyond 6 weeks. So this is a classification which is based on duration. You can also have another classification based on the etiology, as in you can have hematogenous osteomyelitis, which usually occurs in children, and it does occur due to bacteremia, bacteria coming from a specific point or a site in the body to bone. So it could be a boil, it could be a furuncle, it could be maybe pneumonia, So any of those can lead to bacteremia, where bacteria is carried through blood to the bone and therefore causing infection. You can also have exogenous form of osteomyelitis, and this is where an organism comes from outside the body. It could be due to open fractures, like we have people falling off motorcycles and bones digging into the soil and springing back, therefore getting contaminated. Also, you can have introduction into the body by the surgeon, iatrogenic type of infection, and all like when you use an orthopedic device to fix a broken bone, all these lead to infection of the bone. So this is a type of exogenous infection of bone. You can also classify, now this will be specifically for chronic osteomyelitis, whereby we classify using the Marder-Anziani classification. Now, under Marder-Anziani classification, you have intramedullary infection of the bone. This is where the marrow is affected. So there is inflammation where we have that myelitis, where the bone marrow is infected and the infection is constrained there. Then you may have infection on the cortex, or infection involving the periosteum, superficial type of osteomyelitis. So 3, Marder-Anziani will be whereby there is a regional infection of bone. So bacterial infection of bone, specifically on a given part of bone, is type 3 Marder-Anziani classification. So 4, Marder-Anziani classification will be whereby the whole bone is infected. You can say diffuse. So this is the most severe form of chronic osteomyelitis, and sometimes it warrants removal of bone in the management, removal of the whole bone for you to manage or control the bone infection. For example, removal of the humerus, it can be done. I have an experience where I've removed the whole humerus in 2 patients who were pediatric or children, and we controlled the infection. Actually, they formed new humerus forms later. Another patient I had, of course, I think these are now around 3 or 4. These ones we removed the fibula, the old fibula, because it was infected with bacteria, the Marder-Anziani form. So the removal of it controlled the infection, and the child lived a normal life thereafter. So those are some of the few classifications. There are others that you may use in classifying osteomyelitis. Now, looking at the signs and symptoms of osteomyelitis, acute osteomyelitis, which occurs within 2 weeks, the patient may have hotness of the body. Some might call them chills. The patient may not be able to use that specific limb. They experience pain. Some call it functional pain, and they even report hotness of the body. Yeah. So sometimes swelling, which may not be marked. When you examine this patient, you will have some form of swelling. So swelling, hotness or tenderness of the affected part. If it is near a joint, especially for children, you know, the metaphysis is near the joints in the hip, in the shoulder, and also in the ankle joints. So the range of motion of those joints may be affected if the metaphysis near them is affected by osteomyelitis. So those are some of the things you might see. In chronic osteomyelitis, the patient may be talking of swelling, which may be there, but hotness of the body may not be there. Sometimes restricted range of motion because of the pain. You know, patients have pain and they are not able to move the joints nearby, so they end up developing contractures or stiffness. And some may tell you that they have wounds which keeps on coming and disappearing, and those are sinuses. They're called as sinuses. Just a communication from the site where the bone is affected to the outside, so pus keeps draining out using those roots or the sinuses. So those are the things you might see in chronic osteomyelitis. When you do an X-ray for chronic osteomyelitis, you'll be able to see changes, you know, periosteal reactions. You might see dead bone, what we call a squastrum, yeah, and new bone which is forming, we call it involucrum. You might see those, but in acute form of osteomyelitis, you may not be able to see anything. So when you do an X-ray in a acute phase, you might not see anything. So we'll discuss further on what to do when it comes to investigations. So laboratory investigations, then you may do full hemogram. When you do a full hemogram, you may see elevated white blood cells, what we call as leukocytosis, and it might be over 20,000. So that may show you an acute osteomyelitis. For chronic osteomyelitis, they may be elevated, maybe not, you know. So it may not be strongly linked to chronic osteomyelitis. And then for children who are having chronic osteomyelitis, and maybe due to their health status, you may find that sometimes the HB is low. Yeah, for the ones who have had chronic osteomyelitis, it is debilitating and therefore it might affect them. So sometimes the HB is low. Then you do C-reactive protein and ESR. Again, in acute osteomyelitis, you might see elevation of those two. But in chronic osteomyelitis, sometimes the ESR is normal or low, and therefore it may be confusing. But C-reactive protein usually can be used to monitor the progress as you manage the patient. Then other investigations you can do, like you see, we said if you did an X-ray in acute osteomyelitis, you'll not be able to see any changes. Yeah, so for that reason, then we recommend use of MRI. You do an MRI to be able to differentiate the soft tissues from bone, and any inflammation in the bone and even on soft tissues will be able to be discerned by use of an MRI. So it is really recommended when you are in doubt, or if you do an x-ray in acute phase and you see nothing. Ultrasound may not really help also, unless if you have a nearby joint being affected, what we call as compensatory or sympathetic synovitis, it can develop. Though some patients who might be under 10 years who have transversal arteries, the growth plate has not closed, and there's an open artery which is traversing the growth plate. Some of those children may also have septic arthritis, because the vessels will allow for pus to track into the joint and therefore confuse people. Sometimes the first thing that brings the patient to the doctor, it is the swelling of the joint, not the pain in the bone, the affected area. So if you saw a kid coming to you with a swollen knee, and this child is suspected to have septic arthritis and is under 10 years, then also think of a possible chronic osteomyelitis. And like I usually tell some of my students is that if you have such a case and you are going in for arthrotomy for septic arthritis, also open the bone nearby. And we said joints of the shoulder, of the hip and the ankle, in children who might be less than 15 years, there are metaphyses, the site where the osteomyelitis usually occurs are within the joint capsule, and therefore it might confuse one. One might think it is septic arthritis when actually it is chronic osteomyelitis. So during arthrotomy, drill the bone nearby, and if there is a discharge or exudate coming out under pressure, then it means you are dealing with a possible case of osteomyelitis. CT scan may also help. It's better than plain X-ray. So in centers where you have it, you can use it, or you can request for it, so that it helps you to discern the changes that might have occurred due to the infection of the bone, especially in chronic osteomyelitis. Like now, in characterization of the Mardan-Ciani classification, you'll be able to see it better when you use a CT scan. Of course, you may do other baseline investigations which will help in preparation of the patient. And case of osteomyelitis is a possible case of surgery. So prepare them properly so that you know what might preclude surgery, or you may be able to know the patient who needs optimization before they are taken in for surgery. Now, once we have investigated and taken a good history, you've examined, you are able to know the differences. Remember, there are differentials. Like patients may also develop or may have something presenting like osteomyelitis, like Ewing sarcoma, of course, which is a tumor of the bone. It also presents with chills, hotness of the body. It might confuse you when a patient has acute osteomyelitis. So have it in mind, and if you did an X-ray, a plain X-ray, you'll be able to see the changes that occur. Ewing sarcoma usually affects around the diaphysis, and therefore, if you have an adult coming with osteomyelitis, it will confuse you. Yeah, because adults, there's the predilection site for osteomyelitis is diaphysis, whereas in children, it is in the metaphysis. So Ewing sarcoma likes the diaphysis. So what you might see there is periosteal reaction, which looks like an onion peel. You see the onion, which is bulb-like. If you cut it into half and you look down onto it, you will see layers, and that's what you see on the X-ray in Ewing sarcoma. So it will help you to differentiate it from osteomyelitis. But like we say, diseases don't read books. It may also confuse you. If you are in doubt, then you need to do a biopsy. Yeah, so biopsy should be taken so that it can confirm or rule out a tumor. One last thing under investigation that you need to do is culture, blood cultures or culture of whatever you would aspirate, either from the site where there is pain or swelling or the nearby joint. Culture. So culture will guide you in knowing the kind of organism you are dealing with. Yeah. So microscopic culture and sensitivity is important in management of osteomyelitis. And if you find a single organism from culture will mean that that is a possible case of hematogenous spread. If you find many or polymicrobial infection, then it means that is a case of exogenous infection. So microscopic culture and sensitivity is really important. Now, the pathophysiology of the same comes this way, especially with the hematogenous spread. When a patient has an infection somewhere in the body and the bacteria detaches and is carried around through the body, through the blood, to some nutrient artery which is supplying some long bone. You know, once it gets in, it goes directly into the metaphyseal bone. Why metaphyseal bone is affected mostly in children is because of the slow blood, the metaphysis has trabecular bone. It has sinusoids, all spaces in it, and they are U-shaped, and as the blood flows through them, you know, they are slowed down, and therefore bacteria is able to be deposited there, and once it is deposited there, it starts multiplying, and multiplication leads to more bacteria, pus formation, inflammation, and increase in pressure in the canal, and that pressure tries to look for a weak point through which to escape, and that leads to the Volkmann's canals, and therefore coming out under the periosteum. The periosteum gets elevated by the pus, and sometimes the body can contain it at that level, so that you end up with formation of involucrum, that is new bone, and stripping of the old bone. And you know, stripping of the old bone will lead to devitalization. You know, it will lack blood supply, oxygen, and the nutrients, and that leads to the death of that bone, so it becomes the sequestrum. Sometimes the pus which accumulates under the periosteum will penetrate or break the periosteum, lead to pus tracking down into the soft tissues, the muscles, and finally out into the skin, and that will form a sinus. So basically that is the pathophysiology of hematogenous form of osteomyelitis. The most common organisms that may affect or infect bone are bacteria, and the most common bacteria in both ages, not both, all ages. We have the neonates getting infected with staphylococcus, but we also get streptococcus and the E. coli, Escherichia E. coli. And infants, children can also get staphylococcus. They can get streptococcus pyogenes. They can get Haemophilus influenza, and adults mostly get staphylococcus aureus. But then sometimes, you know, depending on the kind of person one is, they might get atypical bacteria, you know, like Bottonella those people who are immunosuppressed, Echinella, Kingella, those ones, Pseudomonas. Those people use drugs or are immunosuppressed, like diabetics or malnourished. They get those kind of bacteria. So that's why I still insist there is a big role that culture, microscopic culture and sensitivity plays in the management of patients with possible osteomyelitis, because they will help you to know the specific organism. You may not just guess, but we say generally the most common organism bacteria is Staphylococcus. And the reason why Staphylococcus is common is because it's mostly found on the skin as a commensal, normal occurrence. And again, this bacteria has an affinity for devitalized bone. It easily gets attached to bone which has been deprived of blood supply, and especially with contamination, maybe due to open fractures. Now, in the management of osteomyelitis, like Ned says, we must start antibiotics early, especially with a suspected case of acute osteomyelitis. So if you give antibiotics before pus forms, before the bacteria has a chance to form pus, then you are able to control and cure the osteomyelitis. So the earlier the better, and the administration should be guided by microscopic culture and sensitivity. But don't stop. Take sample as you send to the lab for MCS, but start the patient on empirical treatment. And the treatment should last at least for 4 weeks, but at best 6 weeks IV treatment of antibiotics based on what you'll find. But because we said Staphylococcus aureus is the most common, it responds very well to penicillins, and for that reason, empirically, you can start your patient on you can start your patient on oxacillin, flucloxacillin, and all that. So for children, you calculate as per the weight, but for adults, you can do 500 milligrams IV QID for the period I said, 4 weeks, sometimes up to 6 weeks. So sometimes in resource poor settings like ours, third world countries, it is difficult to have or admit the patient for that long. So for that reason, you may start to give IV treatment for like 2 to 4 weeks, and then discharge the patient on orals to finish the remaining period. For chronic osteomyelitis, its management is a bit complex. It involves surgery, and the reason is because Staphylococcus forms some form of slime or polysaccharide, as a form of polysaccharide or a coat. You might want to call it a blanket around its body. Now this blanket or slime around its body prevents antibiotics from reaching the bacteria, and therefore the bacteria continues causing havoc in the body. Also this slime, the polysaccharide glycolics prevents phagocytotic activity, where the bacteria gets rid of the bacteria from the body. So it is important that you remove dead bone, the sequestrum. So take this patient in based on Sian and Manda classification, and remove all dead tissues, including soft tissues. Yeah. So no antibiotic is going to sterilize any dead bone or a vascular bone. So bone must be brought out. Any dead bone must be brought out. Any dead debris, any soft tissues that has been infected has to be removed and brought out. And once you do that, take some sample for microscopy, culture, and sensitivity. Again, that will also guide on antibiotic administration, and the patient should take them for a long period. It might be up to 6 weeks or 8 weeks. Like if you use the protocol of suppression therapy, then you go up to 10 weeks. And here you might include use of rifampin, 600 milligrams OD for that period. You can also use clindamycin, 300 milligrams for adults. You use 300 milligrams oral TID for the same period. In children, the clindamycin will be half the adult dose. That will be around 150 milligrams per oral TID for the same period. Include quinolone. The one which I prefer is levofloxacin, where you use up to 750 milligrams BD for the same period of time. So if you don't have levofloxacin, you can do ciprofloxacin. So in both acute and chronic osteomyelitis, because of the inflammation and pain that may be there, also give an analgesic. Here we allow use of non-steroidal and inflammatory drugs, NSAIDs. There are so many of them. So it can be ibuprofen, it can be diclofenac, it can be meloxicam, it can be pterocoxib. There are many. So also give them so that you reduce the pain and inflammation, and also include protection of these bones. There are some which are affected and they are at risk of fracturing. If, for example, the kid is playful and there is a weak point that has been caused by the osteomyelitis, so you can protect these bones. Maybe use of splints or back slaps, and that will really help to prevent pathological fractures. Physiotherapy can also be included because of the stiffness that or contracture formation around the joints that may be involved. So some of the complications that these patients may get when they get osteomyelitis include pathological fractures. Patients, the infection weakens bone, and like we said, if the child is playful or is heavy, the bone can easily break. Transformation of, in chronic osteomyelitis, transformation of the cells at the sinus site to squamous carcinoma, squamous cell carcinoma. So it can become malignant, but it's rare, it's around 1% or less. These patients can also develop stiffness or contractures around joints, especially the knee joint, if the femur or tibia are affected. So these patients may have contractures. And then you may have deep venous thrombosis because of resting, no movement, and deep venous thrombosis can lead to thromboembolism. So those are, there's one more, loss of limb. Sometimes we debride a lot and you can remove most of the bone and you end up with a bone defect. So bone defect may necessitate maybe management of bone defects by use of grafting or bone transport, or even vascularized fibula. Also, you might even amputate, and therefore the patient becomes permanently disabled. So thank you very much for listening to me. You can comment there and add some more notes to what I've missed. So thank you very much. Subscribe to our channel, like and share.